Good evening, everyone, and welcome to another session of Intellectus Campus. I'm sorry about the late change, but the other speaker had a personal emergency and was unable to speak. So we are going to cover tonight substance use in HIV. They tend to go hand in hand. Before I continue, can I just confirm with you, Pride, that you can hear me?
Yes, we can hear.
Brilliant. Okay. So I'd like to start off with substance use in disorder in HIV. And I'd just like to look at it as an integrative approach to this. I'm going to start with a case history because I think that the case histories are a lot more meaningful in this sort of situation. So we're going to start off. I'm just going to check the slides are going to project. They are projecting. Can you see the second slide?
Yes, we can. Oh.
Excellent. So we'll start off with a 51-year-old male. He's HIV positive on ART, and he's on TLD, and I'll go into why this is important at the moment, because TLD is the recommended first-line treatment, according to the public health physicians, but it can cause some significant psychiatric side effects. So for those of us who deal with HIV patients, it's a good idea to use differentiated treatment and not necessarily only go for the public health approach to try and individualize patients. The patient has been drinking 2 to 8 units a night for stress and to sleep for many years. Previously, he drank excessively socially. He binge drinks a week or so, and he's divorced. He's depressed. He's tried SSRIs, but his insomnia got worse, and he felt worse. He's now on a liver detox. He stopped socially interacting months ago, is never really outside. He works and goes home and then drinks in front of his TV. And absolutely nothing gives him pleasure, which, as I'm sure you know, is known as anhedonia. The detox he's taking is listed. It contains turmeric and aloe vera and milk thistle, which are fairly well known, and black pepper, which can increase endorphins. But he's come to you now not knowing what to do. He developed irritable bowel symptoms, including diarrhea, after a binge, which have not resolved for a week. He's feeling miserable. He's tried to stop drinking. After 1 to 2 days of severe craving, anxiety, insomnia, sweating, shaking, and nausea, he went back onto alcohol, which stopped the withdrawal reaction, and he's tried again to stop with the same result, but it's worse, and he's come in looking for help. So the one thing I wanted to just go into is looking at the ARVs your patients are on. Now, I'll also go into a little bit later the reasons why patients on ARVs are more prone to depression, which is fairly obvious. But this patient was switched from TDF to TAF. And the reason was multiple, not only improvement of mood and insomnia, but there's an increasing need to change from TDF to TAF to stop the renal impairment that comes from tenofovir, and also dolutegravir dolutegravir specifically can cause severe insomnia. So the decision was made to switch. Now, just going into the neuropsychiatric side effects of dolutegravir, These side effects are observed with the integrase strand transferred inhibitor, and they're usually mild to moderate, but the most prevalent symptoms are insomnia and sleep disorders. But the spectrum can include dizziness, anxiety, depression, headache, paresthesia, musculoskeletal pain, poor concentration, slow thinking, and in recent cohort studies, discontinuation rates were observed in about 3.5%, basically based simply on the neuropsychiatric side effects. So it's something to be looked at. There's a big move by Gilead to change from TDF to TAF where possible, particularly because of the renal and the osteoporotic effects. And when we look at treatment-related adverse effects, one size does not fit all. We have an aging population living with HIV, and we should be treating people and not HIV and viral load. So we need to recognize those patients that are at risk of treatment-related adverse events. We need to specifically know about renal disease and osteoporosis, and many of these patients do not have the funds to have this monitored. Obviously, metabolic syndrome is an issue with dolutegravir, and the neuropsychiatric side effects are often underrated in the reasons for a switch. Now, just to go through the ARVs, if we look at plasma versus intracellular concentrations, when we use tenofovir, the vast majority ends up in the HIV target cell. Whereas when we use, let me rephrase that. If we use tenofovir and we use the aliphenamide fumarate, which is TAF, the vast majority ends up in the HIV target cell. Whereas when we use the disoproxil fumarate, much ends up in the bloodstream and not very much ends up in the cell, and it affects the renal tubules. And these patients can go into renal failure at a fairly young age. In addition, if we look at bone density, we know that TDF causes reduced bone mineral density in the spine and in the hip. And if we look at it over time, we can get spinal fractures. And there's also an unusually high incidence of hip fracture in patients who are on TDF. So we need to be very cautious about using it in patients with bone mineral density over time. What we do know is if we switch to TAF, what we do get is a change from the baseline to week 14 and all the way through to week 48 as well. And what we can see is a reversal of this bone mineral density. Now, if we get onto the addiction side of things with the insomnia, this patient started off with problems with insomnia, obviously with multiple other problems as well, and then ended up with both alcohol and benzodiazepine addiction. And as time has gone on with all of the problems that he's got, he's developed quite severe disconnection with society. And just getting him sober is not the same as getting him connected back with society. Now, when we look at the burden of mental and addictive disorders, it's 7% of the global burden of disease. It affects more than 1 billion people, and that was in 2016. It must be a great deal more now. And depression is strongly associated with this. There's a suicide every 40 seconds globally. And by 2030, according to the WHO, at the moment, it's currently the fourth leading cause of global burden of disease, but it will be predicted that it will be ranked second by 2020, and by 2030, it will account for the highest level of disability attributable to any physical or mental disorder worldwide. Now, Zimbabwe has an estimated total population of 15.2 million, and that means over 5 million children aged 10 to 24 years are at risk alone, and this is a severe public health and socio-pathological threat facing adolescents and young people, and will strongly affect their long-term future. Now, a recent UNICEF study showed that lockdown made this a great deal worse, both for HIV and for substance use disorder. And this has significantly affected the mental health of young people. Now, why do young people use substances? And the main reason is novelty. And it's wondering what is next. Once they have started, they get desensitization, tolerance, and what was considered extreme barely elicits a response. And that can lead to some pretty dark places. So we are not created to live mundane lives that do not seek novelty, which leads to innovation, adaptability, and is a survival advantage. But we must ensure that we're channeling this part of our nature in the correct areas of our lives. The irony here is that when addicted, the capacity for creativity and thinking out the box and exploration dwindle, and the pursuit of novelty is completely wasted in addiction. One of the things that's important is, and it's a difficult situation because locking people up in isolation and mundanity is actually going to make the problem worse. But if you have a patient earnestly seeking freedom, one of the best things you can suggest is that they take on new endeavors that add meaning to their life. But this is very difficult in a situation like the patient that we are discussing. Now, some patients use substances for artificial exhilaration. They are bored, they have nothing to do, and as a result, they end up with HIV and substance use disorder. And the combination is very, very, very difficult to treat. It affects the frontal limbic circuit, there is loss of control, and the brain is basically hijacked by dopamine-releasing substances, such that there's a binge or intoxication, and then that is followed by withdrawal or negative effect, and that is then followed by preoccupation and intoxication again. So you end up in this vicious cycle. Sleep is extremely important. You will find that, and especially on dolutegravir, you have decreased sleep onset latency, increased wakefulness during sleep, modest decrease in REM, and delta and alpha power also increased, all of which do not help the situation in any way at all. And it turns into a family disease because everybody becomes affected. There is conflict. There is a lot of the individual doesn't really know what's happening to them. And then there becomes argument in the family because people don't understand why they cannot stop. Now, if we look at a map of consciousness, and I've shared this before, but they say it takes 7 times to share something for people to understand it. If you treat someone as with shame, guilt, and anger and disappointing, the result will be scorn, craving, despair, blame, humiliation. And patients need to know other ways of getting out of this. And one way is reason, but they need to move up in a map of consciousness. And sometimes showing this to patients can make a difference. Sorry, my screen's not moving. The death by duvet. The patient develops severe anhedonia, severe fatigue, very low mood, no motivation, brain fog, irritable bowel, and essentially the term is death by duvet. In this particular case, the GP diagnoses HIV, alcohol use disorder with severe depression, advises admission to hospital for detox, and then advises referral after detox for referral for admission for rehabilitation. And this cost is 6,000 US, for which most people is not affordable. The other alternative is a referral to psychiatry, which involves more pills. And the patient declines that they've been down that route before. They don't want to go down that route again. So the next thing comes in, what now? What can you do? You can't cure this, but you can improve it. So one of the things to do is to manage the depression first. And you need to check there are no contributory nutritional deficiencies. Vitamin C, vitamin D, zinc, thiamine are the big ones. You need to fix the gut. You need to manage nutrition, remove toxic substances, improve immunity, and get into psychological rehabilitation. Now, this sounds, this is a very long process. You're talking 6 months to a year to actually get this right. So, if we look at conventional treatment, your standard bloods would involve your HIV bloods, a standard FBC, UNE, LFTs, a check of vitamin D, homocysteine, B12, and hormones, including testosterone, liver imaging. Consider starting an SSRI. Consider treating with a short course of diazepam to reduce the severity of symptoms. And one of the things a lot of GPs completely forget is to use thiamine, and that should be at a milligram at least 2 to 3 times a day. And the patient needs to be in a place of safety. If we look at our patient, he is effectively malnourished. He's got 0 sunlight. He's getting very high levels of stress. His gut health is poor. Let's look at thiamine specifically. Up to 80% of people develop with alcohol addiction, develop thiamine deficiency. It causes inflammation of the stomach lining and the digestive tract, which reduces the body's ability to absorb vitamins. And poor dietary choices and a lack of nutrition also rob the body of essential vitamins. Thiamine deficiency can cause loss of appetite. It causes constipation, fatigue, blurred vision, changes in heart rate, irritability, nausea, vomiting, reduced reflexes, tingling, often a burning sensation in the arms and legs, shortness of breath, and muscle weakness. So if we look at the progress of alcohol withdrawal symptom, it's very similar to thiamine deficiency. Obviously, seizures are the main thing we want to avoid. But anxiety, agitation, tremor, nausea, tachycardia, hypertension, disturbed sleep, and raised temperature are one of the things that we need to avoid. With severe withdrawal, you get vomiting, extreme agitation, disorientation, confusion, paranoia, hyperventilation, and DTs. Now, the mortality rate from DTs is up to 40% if untreated. So, going back, we've been through the African solutions for African problems. Another major problem is that patient understanding is needed for compliance. Mental illness in Africa is a taboo subject that attracts stigma in much of Africa. A study conducted in Uganda revealed that the term depression is not culturally acceptable among the population. And so social stigma has meant that in much of Africa, mental illness is an issue equated to a silent epidemic. Now, many households with mentally ill persons hide them for fear of discrimination and ostracism from their communities. Girls from homes known to have mental illness are disadvantaged, and the fact that any female in the family which has mental illness is disadvantaged because it severely reduces their marriage prospects. So the effect of the silence is further compounded by inadequate focus at policy level. In Zimbabwe, the term kufungusisa is used, which is also called the disease of thinking too much. So kufungusisa is a non-psychotic mental disorder, which is very common in primary care settings in Zimbabwe. Sociocultural factors play a profound role in the manifestation of such illness and local idioms, and the concepts of such illness need to be understood and related to biomedical psychiatric concepts which originate in European and American cultures. It's used to mean both a cause and a symptom of illness. Both patients and care providers view this term as being related to mental, social, and spiritual distress. The term is strongly related to biomedical constructs of non-psychotic mental illness, but it's not specifically related either to depression or anxiety. In the West, they would probably call it feeling stressed. It may increase awareness and recognition of non-psychotic mental illness by the community and may be more acceptable to the patient. It is, I'll skip that slide because it's a repeat. The association of thinking too much with mental health problems is thought to be innovative if we look at Japanese journals, but it's not at all. Thinking too much is an obstacle to people moving forward in their lives. You can't figure out life in your head. And highly intelligent people who attempt to figure out life in their head are often the ones who suffer. And the lack of intellectual resolution often leads to a lack of action. So if we look at what the Japanese do, they have a book known as 30,000 Days, which I'd recommend. It is a natural approach to mental wellness, and it's called The Art of Taking Action, and they use a lot of meditation. So, psychological strategies that can be used. The opposite of addiction, as we've discussed, is not sobriety, it is connection. And this link goes through the fact that everything that people think they know about addiction is probably wrong. Ostracizing, isolating, and locking somebody up may actually make the problem worse. We know that substance use disorder in Zimbabwe is becoming a massive problem. It's becoming a massive problem globally, and we need solutions to it. Now, in Zimbabwe, Dr. Dixon Chibanda has developed something called the Friendship Bench. What he has done, because there were a very limited number of psychiatrists, he has trained grandmothers in cognitive behavioral therapy. And so there is someone for some of these people to talk to. Life is becoming increasingly isolated in many areas. It creates empathy, it creates belonging, it creates connection. So the psychological part of treating the person is able to be delivered, because there's no way that 12 to 14 psychiatrists can look after 14 million people. So the story of the Friendship Bench goes through a woman called Farai. She's suicidal. She's HIV positive. She's the mother of 2. And there was a famous lady who unfortunately has passed, whose name was Grandmother Jack. Her well-known phrase was, "I'm here for you. Would you like to share your story with me?" 6 sessions later, Farai was employed, was productive, had purpose and meaning in her life, and had a gogo, which in the African languages means a grandmother who cares about her and makes her feel as though she matters. Now, if we look at what's happening in Canada, they've got a massive problem in Vancouver. Professor Bruce Alexander is well known in Vancouver. He's a retired psychologist and an emeritus professor, and he's taught and conducted research on the psychology of addiction at Simon Fraser University since 1970. In 2007, he received a prize in support of controversy from the Simon Fraser University. Now, one thing that is very interesting is what we call rat park experiments. So Professor Alexander was well known for taking rats and putting them into an isolated environment, as well as into a rat heaven park where they could do what they wanted to do. And there was basically what he showed was that the worse the environment, the worse the addiction that the rats developed for morphine. So environmental enrichment will induce neurological change that will serve to decrease the chances of opiate addiction. And we have to look at the social side of addiction. Addiction is more of a social problem than an individual problem. Drug addiction is only a small corner of the addiction problem as well, because there are addictions to many other things, including social media and behavioral addictions. So when socially integrated societies are fragmented by internal or external forces, addiction of all sorts increases dramatically. And it can become almost universal in extremely fragmented societies. So people use it as a way of adapting to extreme social dislocation. So social dislocation is actually the problem, and people see whatever they become addicted to as the solution. as a form that can be cured, nor is it a moral error that can be corrected by punishment and and education. So we have to really watch what's happening with our young people at the moment. Our young people at the moment, I've just been watching, and people are completely addicted to their screens. Now, they are unaware of this, but it is a way of forming a connection. And substance use disorder is, at least in part, a disease of modern societal dislocation. What can be done? Well, if you are the primary care physician, you can start with some basics. The substance must be stopped so the brain can heal. You need to stop the craving. Now, the craving comes from two areas. One is a withdrawal. The second is often the person's conscience because of what's happened while they've been in addiction. Now, there are nutrient and herbal strategies and behavioral changes that need to be made. There are online resources, and there are plenty of those. Recreating communities becomes very important. The friendship bench is a start. It is a form of CBT, but we need to be aware that we need to recreate communities. We've been focusing on integrative health, and part of integrative health is to recreate communities. Neurolinguistic programming is another form of psychological therapy, so is medical organ therapy. And communities that are not socially fragmented have much lower incidences of these conditions. And socially fragmented, this is a lot easier said than done because this is not a medical problem. This is a political problem. It's a societal problem. And it goes way beyond just a medical problem. So we need to turn someone from somebody who is disappointing and therefore has craving and can have any of these other symptoms that are included, which include aggression, withdrawal, despondency, abdication, destruction. And we need to turn them into somebody who has a life that is meaningful. And this is a lot easier said than done. Relationship issues are a major problem. And one of the very good online resources for relationship issues is Esther Perel, The Management of Stress and Uncertainty, Healthy Boundaries, Routine. Another resource is the power of relationship intelligence, people who have purpose, people who have meaning, who have fulfillment, who have passion. Now, if we look at people who have had problems with addiction, Robert Downey Jr., remember that just because you hit rock bottom doesn't mean you have to stay there. Anthony Hopkins, if you're an alcoholic or a drug addict, we flirt with death. We pull ourselves to the brink of destruction, and if we're lucky, we pull ourselves. We all have that in us. Robin Williams is very well known for his issues with rehab. And I like 3 of his quotes. Please don't worry so much, because in the end, none of us have very long on this earth. Life is fleeting. Make your life spectacular. The other one I like is he says, you're only given a little spark of madness, you mustn't lose it. But I think there's also important words for family members, which was that I used to think that the worst thing in the world was to end up alone. It's not. The worst thing in the world is to end up with people who make you feel alone. Now, getting back to the community, it has been demonstrated in clinical trials that grandmothers can have their skills upgraded and can perform excellent CBT, and trained grandmothers outperform doctors. And this is probably because of the way that medicine has gone, which is very much a pharmaceutical and a 5 to 10 minute consult, as opposed to the traditional family doctor who knows the patient well and who they've been seeing for many, many years. Now, going back to nutrition, nothing will work until nutrition is corrected. So the first thing is to stop the toxic substance. The second thing is to reduce the craving. The HPA axis and cortisol reduction. If you reduce cortisol, which can be done with a substance called ashwagandha, you will usually improve things. Don't promise your patient a cure. There isn't a cure. But you can improve and reduce the withdrawal reaction. Restoring the microbiome, reducing neuroinflammation, improving mitochondrial function, and psychological rehabilitation are also very important. If we go back in time, in 1977, Libby and Stone realized that an addiction is both a disease as well as poor nutrition. Addicts are particularly deficient in vitamin C. They also are deficient in other vitamins, minerals, and protein. Genetics and bad lifestyle may have contributed to their disease, and certainly childhood trauma and trauma throughout their lives would have contributed. But conventional medical therapy is almost useless until their nutrition is restored. And I have put the link for that on the slides. They demonstrated that they were able to stop 30 out of 30 opiate addicts, and in fact, 30 out of 30 drug addicts, regardless of the type of drug. The cure is temporary because the patients were only followed for about 30 days, and they did not have time to evaluate and treat the basic cause of the addiction. However, the treatment for basic causes can proceed with greater expectation of success because the patients have been properly nourished. Vitamin D. Many with addiction problems will not have had any sunlight for months, particularly those who have gaming addictions. And gaming addictions are becoming a real problem globally. And I think we need to be teaching this at quite a young age at schools, because prevention, an ounce of prevention is a lot better than a pound of cure. So let's look at how vitamin D affects mood. Vitamin D deficiency is associated with depression, and this may relate to the role played in neuromodulation, neuroprotection, neuronal growth, neuroplasticity. Now, recently, we were discussing a patient at a doctor's meeting who had been in hospital for 6 months, and he hadn't been outside, literally, for 6 months. And ultimately, he passed. Now, if it's not very difficult to get a patient out into the sun for an hour or so in the middle of the day, or even less. We make, if you are light-skinned, 1,000 units a minute, and if you are dark-skinned, a third of that. And so spending time out in the sun will improve things. This is definitely not a cure, but it is something else that you can do. There's also work that shows that vitamin D deficiency, if you are deficient, and that is less than 70 nanograms per mil, it exaggerates the craving for and the effects, particularly of opioids, and supplements may help combat addiction. Getting onto dopamine, we know that dopamine is our reward. It is our feel-good neurotransmitter. And the vitamin D receptor is very, very, very involved in basically the production and the breakdown and the whole metabolism of vitamin D. So in depressed HIV patients with substance use disorder, I would certainly educate them that vitamin D, if they are motivated to get better, it will significantly help them contain many of their symptoms. It improves immunity, which is good for your HIV positive patient. It reduces cravings, it improves mood, and it improves bone health. And largely in Africa, it is free, which is a blessing that we have compared to other parts of the world. Movement is therapy. The movement of people, particularly crossing the midline, it improves other brain pathways and helps healing. And if we look at the reduction of craving, we've got vitamin C, vitamin D, selenium. The main herbal remedy I would go for is ashwagandha because of its effect on cortisol. Getting the microbiome right is extremely important. A lot of these patients have been in the past on lots of antibiotics, and probiotics definitely do make a difference. There have been anecdotal cases, certainly coming out of Malibu and Sydney, where people who have fecal transplants because they have C. diff will actually wake up and will no longer crave. Improving the nutrient state, exercise, sunlight, and support, and basically all of the above. So I've also attached another link here for neuro-linguistic programming, unconscious versus conscious thinking. When there's incongruence between the conscious mind and the subconscious mind, there are disturbances. The patient wants to stop, but their subconscious mind often doesn't want to stop because it wants relief from the withdrawals. You need to access the subconscious and form an ally with the subconscious mind and validate the intention of the subconscious mind. There are neuro-linguistic programmers that do lecture, John Grinder being one of the most important ones. The link is there. It is very difficult to give anything up because you create a mental image of it. So if you say, I'm not going to think of a cigarette or I'm not going to think of gaming, you will create a mental image of doing that. But you can replace it by finding something that does for you what the substance actually does for you. In terms of holistic management, I would say, therefore, overall, you would want, obviously, to look at the medication that they're on and make sure that you're not making them sicker with some of the drugs you've put them on. Then you need to manage the depression. You need to check there are no nutritional deficiencies. A lot of in Zimbabwe, certainly B1 is only on prescription because it's an imported substance. You need to fix the gut, which you need to be doing with diet. And you also, with prebiotics, garlic is a very good prebiotic, onions are very good prebiotics, and you need to be able to manage the patient's nutrition. You need to remove the toxic substances, and most importantly, where you can, you need to improve immunity. We've been through orgone therapy in a previous discussion. It addresses both the psychological and the underpinnings of chronic emotional distress. It talks about the nature of life energy. And Reich termed this orgone. He said basically that the body and the mind are not separate. Freud believed that as we grow up, we learn to cope with intolerable emotional distress by means of unconscious defense mechanisms. And by pursuing this, Reich was the first Western scientist to fully demonstrate that the mind and body were one and the same and were inseparably linked. And Reich also demonstrated that inhibited breathing, chronic muscular tension, and fixed patterns of thinking and behavior were reflections of the same defense mechanism. And he called those defense mechanisms armoring. Now, armoring results in emotional blocks, and bound emotions may release painful symptoms like depression, confusion, anxiety, and inappropriate rage, and other self-defeating behaviors. It also allows a deeper capacity to assertively reach for desired goals, such as joyful work, creative pleasures, and the capacity to feel deeply, think clearly, and see the world realistically. Armoring is actually beneficial at the time because at the time it protects us from overwhelming protective thoughts and emotions and temporarily allows us to continue to function. These reactions should, however, be short-lived and deal with the threat and then be dropped and bring us to safety and then drop the armor. But if adverse stimuli are severe enough or continue for an extended period of time, the physical, emotional, and psychological defenses become chronic. Over time, armoring can become chronic or stuck, disrupting the free flow of our energy, leading to us becoming trapped in patterns of living that are unfulfilling or even destructive. And we either feel or exhibit many symptoms of emotional distress and become trapped in patterns of living that are not fulfilling when we become locked in our own armoring. It should only be a temporary pattern of defending oneself during emotionally distressing events and reactions and behaviors that were designed to keep us safe. So in order to literally get your life back, you have to undo blockages to the flow of energy and blockages that occur that have not been able to develop the capacity to fully feel, express, and modulate our emotions. When emotions are blocked, so is energy. Another person I'd recommend, if you've got patients like this, is to get them to listen to Gabor Mate, who talks about not numbing your feelings. He's very, very well known in Canada, specifically in Vancouver. We have a Zimbabwean doctor working in Vancouver that works with him. And one comment that I think is very important here is that unexpressed emotion tends to be buried alive. And like any living creature deprived of air, comes to the surface months or years later, demanding its time and toll on the human spirit. And also realize that the person who is suffering from addiction asks not what the addiction is, but what the pain behind it is. He also is very strong on the fact that people must set boundaries and that being too nice will ultimately kill you. So one of the questions really is in our areas is how do we recover from this mess? And it's going to take time. Life is about expectations, calibrating expectations, and diversifying deep connections. And I really do think that the cell phone world that we now live in stops many deep connections forming. Intimacy means sharing yourself with people that are important to you through the stages of your life into the big events of your life. And these are probably the secrets. And gradually over the last couple of decades, they've been eroded away. The youth advocates of Zimbabwe are called YAS. They have developed a training which consists of a 1-month online training course. And there are modules including leadership, COVID-19, HIV, AIDS, physical development, sexual reproductive health rights and responsibilities, mental health and gender norms, as well as values. And one of the students said she felt empowered to help others overcome challenges similar to those she faced as a young single mother. In the US, about 5,000 people under 21 die in alcohol-related car accidents a year. I don't know the figures for Africa, but I would say it's probably not too dissimilar here. So the other service is the International Citizen Service. And they use the power of sport to bring disadvantaged youth together and start reconnecting them with the tough issues they face in their communities. And it really will be the combined efforts of our communities that will change things in the long run. So between years, the grandmother's friendship bench and training young people, we may have a chance to change some of what is going on, but there's certainly no quick fix. And unfortunately, many of these patients are in a position when it actually happens that they are they've let it go too far. It needs to be recognized a great deal earlier. And as said before, it takes a village to raise a child. So the opposite of addiction is not sobriety, it is connection. And I really would encourage you to read or to have a look at some of these links. Pride, if you can post this on the chat afterwards. So the two sort of take-home messages, or the three take-home messages, I think, for doctors and healthcare workers on this call would be, number one, recognize that the person who is taking something is doing it as to relieve a symptom. And if you can find somebody who can counsel that person, it's a good idea. The second thing is be very, very careful of starting addictive drugs, particularly benzodiazepines. They release a lot because many of them are mitochondrial suppressants. Many of them will actually be making the depression a lot worse. And with your HIV patients, just have a look at the DTG. If they're on DTG, they're probably not sleeping. The next thing is they get prescribed a sleeping tablet, and then you'll find the next thing is the sleeping tablet doesn't work, and they start getting tolerance and they increase the amount. So I'm having a look at the time now. It's 19:27. I'm going to stop it there. And I can see that W Beta has their hand up. Would you like to unmute your mic and make a comment? No. The question.
Sorry, Jackie. That was an error.
So what I'm going to have to ask the tech team to do is to put it in tomorrow in a way that there's a link. Pride, can that be done?
Yeah, Doc, can you come again?
Is it possible to turn the slideshow into a link so that because I know from earlier that we couldn't exchange the slides because it was too big for WhatsApp.
All right, just work on it in the morning, then we'll send in the call.
Okay, so we can definitely do that in the morning. I'm having a look at the chat. Oh, the Japanese book, I'll actually have to go back to it because I've gone blank on it. But it really is about taking action rather than overthinking everything. And I can actually go back and have a quick look for it. I'm just scrolling through the chat just to be sure. I think that's all the questions answered. And we are at 19:30. So Anybody else that wants to make a comment? Would like to know any more about medications that cause depression, that kind of thing? Nope. Okay.